This is a very brief overview of supplemental oxygen delivery for physical therapists. It will cover our role in dosing oxygen and why we would titrate oxygen administration, as well as equipment needs and considerations, delivery devices that are available, and non-invasive mechanical ventilatory support. The objectives of this lecture include understanding the PT role in oxygen delivery, comparing and contrasting supplemental oxygen delivery devices, discussing FiO2 and how to determine the FiO2 delivery amount, and comparing and contrasting non-invasive oxygen delivery methods. Because oxygen is a drug, there's much to consider regarding administration and adjustments that physical therapists can make. We can dispense medication, consider the use of medications during iontophoresis, for example, with a prescription. In the case of oxygen, it is dependent upon how the physician writes the prescription for how much leeway we have in adjusting. Only in an emergency situation may we administer or up a dosage amount of oxygen without proper prescription to do so, and desaturation in and of itself does not constitute a medical emergency. So the APTA position on oxygen delivery is as follows. The physician orders must be written in a way that allows the therapist to titrate for need, and under the guide of a PT, under the guide to PT practice, there is a section on the use of support devices. Oxygen falls into that category, and therapists are taught pharmacology in school and apply that to the practice daily. And so storing oxygen and titrating it under the correct prescriptions from the physician is well within the scope of practice for practicing therapists. This is becoming more and more important because therapists have more clients with complex medical issues, even in outpatient clinics that have more pulmonary diagnoses. Think of our COVID-19 pandemic and the lung issues of our chronic long hauler COVID patients as an example of this. And because people are living longer and longer lives, there comes more need for pulmonary support at a higher frequency than years ago. So this really comes down to how orders are written. If flow rate is what is specified, we cannot adjust. This means we may need to educate our physicians regarding the needs and responses of the patient. Often the therapist is the first to note that the flow rate prescribed while the patient is in bed and quiet certainly is not high enough during activity with us. So as therapists, we can ask that a physician write the orders that allow for titration and changes in oxygen amount based on activity level and tolerance of the patient. This order is written not by flow rate, but by SpO2 level maintenance instead. So for example, it may be that the physician writes, please titrate oxygen to maintain SpO2 above 88 to 90%, that's the usual amount, with all activities. And this gives us the freedom to move through and use oxygen appropriately. This ability to adjust oxygen based on SpO2 level gives us flexibility to treat our clients safely and effectively. This is through all of these things listed here and so many others. So this includes things like decreasing shortness of breath, decreasing dynamic hyperinflation, prolonging exercise tolerance, improving sleep and mood, mental alertness and stamina, and preventing delays in heart failure and severe lung disease. Enough about the prescription management. Let's talk more about delivery devices and equipment now. So some equipment needed will include a pulse oximeter. Certainly if we have orders that allow us to titrate oxygen to maintain specific SpO2 levels, then we must monitor that patient's SpO2. We need an oxygen supply. In acute care, that might be via a wall unit and tubing, or portable oxygen tanks both in and outpatient cases as well as in home health, which make mobility that much easier and effective. Though we must keep in mind the added weight of an oxygen tank and its unilateral pull on a client can affect their energy level, their balance, and their endurance. Then we must consider the mode of delivery. Are we using a mask, a nasal cannula, etc.? So let's chat for a moment here about those things. So remember, a tank weight can be anywhere between 5 to 20 pounds, and certainly that is going to have an effect on your patient. So let's talk about a couple of other considerations here. Adding supplemental oxygen is to increase the FiO2, the fraction of inspired oxygen, to match the oxygen demand that's required at that moment. It improves the gas exchange and it can ease the work of breathing of our client. So FiO2, that's the fraction of inspired oxygen. The room air you are currently breathing is 21% FiO2. And so as we increase each liter per minute, we're increasing the FiO2, the inspired oxygen for that patient. So in the first 1 liter per minute increase, that's a 3% increase. After that, each 1 liter is an added 4% increase. So for example, if room air is 21%, adding 1 liter per minute makes it 24%. 2 liters then goes up by 4 at 28 and 3 liters per minute at 32, and so on and so on. Keep in mind that humidified air is preferred if FiO2 is above 30%, simply because it dries out the airway passages. So there's plenty of oxygen delivery devices. We're going to talk about many of them. Let's start with the nasal cannula. This is an easy and non-restrictive component with 2 prongs that insert into the nose, hooks around the ears, but the capacity for this is 6 liters per minute max. Pros are it's really easy to don and doff, and it's not restrictive, and it's cheap. But the cons are that at greater than 3 to 4 liters per minute, you even then need that humidified air to prevent the drying out of the nasal mucosa, as well as the capacity of only 6 liters per minute max. And if I happen to be somebody with a stuffy nose or mouth breathing, it's going to have very little effect for this to be sitting in my nasal passage. It also is very easy for patients to accidentally knock this out of their nasal passages, and then they're oxygenating their eye or their ear. Addition of an oxidizer, you'll see that here. What this does is it traps extra oxygen for delivery per breath. So it increases the FiO2 by 1 liter per minute over whatever your setting is. So for example, if the goal is 32% FiO2, then we can get that via a nasal cannula at 3 liters per minute, or via a nasal cannula with an oxidizer at 2 liters per minute. And then we have high flow nasal cannula. So a high flow increases the diameter of the tubing, which allows for faster flow rates. Up to 15 liters per minute can be delivered. However, sometimes that's thought that due to that high flow, the delivery is actually 1 liter per minute higher FiO2 than whatever the setting is in those cases. Then we have heated high flow, or airvos, and that is this picture here. And this, you can do flows of up to 60 liters per minute and 100% FiO2. And the air is heated and humidified, but it's extremely difficult to transport this. So this would be bedside level activity only. And if a client, again, is stuffy or breathes through their mouth versus their nose, then we can use a simple mask like this one pictured here. This you can do 5 to 10 liters per minute of effective delivery, because they are going to be rebreathing. We can't get much above 55%, but FiO2 somewhere between 35 to 55% is effective with a simple face mask, particularly used on our patients who cannot breathe through their nose well. So these are simply the different things that we've just talked about. We have our nasal cannula, remember, about 6 liters per minute max. Then we have the high flow. Remember, this is 15 liters per max because of the larger diameter tubing. We have our mustache and pendant oximizers. Keep in mind that these simply are just a reservoir to hold an extra liter per oxygen per breath, so to speak. And then we have our simple mask. Remember, we can get up to about 35 to 55% FiO2 off of a simple mask, and often use this in cases where breathing through the nasal passages is either difficult or impossible. So when more support is needed, and that is provided by the nasal cannulas, high flow, low flows, or in different instances, we may see that the patient is using a Venturi mask. This is a simple face mask that has an attachment that allows for us to dial up the fraction of inspired oxygen. So we set a flow rate with the liters per minute, and then we can use these different colored dials to reduce the attenuation of oxygen that's flowing through and increase the amount that's going into the face mask itself. So the patient is still rebreathing air in the mask, so the highest flow rate setting is about 50% FiO2 at its max flows. When a client needs more than 50% FiO2, we have to consider rebreather masks. So there's a partial rebreather in which basically it has this huge reservoir, kind of like the reservoir on the oximizer, only this one holds 15 liters per minute of flow that's trapped in this oxygen bag. Plus then they're receiving 15 liters per minute of flow. And so this can increase the FiO2 to 50 to 70%. It is safer than a non-rebreather due to the air holes on the sides here that allow for air room leak. So if oxygen stopped flowing, this person would then begin breathing air from the room that is at that 21%. On a non-rebreather, this is the O2 that's inhaled from the bag and this flow all goes straight in. And then there's a one-way valve, so no room air is getting in through a mask that's a non-rebreather. So if this O2 flow were to stop and they can't get any room air in, then that would become an emergency because they cannot breathe. So these are used in an emergency situation with severe desaturation. It's short-term use. Often this is the last step before somebody would be intubated. And then let's talk really briefly about little kiddos. If we cannot fit or keep a simple delivery device on, and we still want to allow touch and movement while we're delivering oxygen, then we can put a whole oxygen hood on or just a hood over the head and around the neck of the baby or child so that they can still play and move and be touched and cared for, but they don't have these masks or nasal cannulas on their faces. And finally, we're going to talk a little bit about non-invasive mechanical ventilatory support. So what is it? It's support through the upper airway using a mask or a similar device, but with pressure. It does not bypass the upper airway system, therefore it's non-invasive. So some general indications is patient cooperation. They have to be able to tolerate the machinery that is required for this. If a patient is severely dyspneic and tachypneic and has an increased work of breathing, then we may consider using this. If they're hypercapnic or hypoxic, then we may consider this. This is really the last ditch steps before an invasive mechanical ventilation sometimes. So some clinical conditions that are appropriate would be severe COPD, cardiogenic pulmonary edema. After I've weaned off of a vent and now I'm still working on breathing and you don't want my work of breathing to be so severe. Asthma, if I'm DNR. Postoperative respiratory failures, neuromuscular respiratory failures, cystic fibrosis, and decompensated cor pulmonale are all some considerations we could consider there. So negative pressure ventilation. The iron lung was the first of these that was used in poliomyelitis in the late 20s and on. The Cura shell is a currently used component of a negative pressure, and that's in this photo at the bottom here. Basically, in both of these cases, what happens is that there's a vacuum to reduce the pressure around the thorax below the atmospheric pressure. And therein, the thorax expands, the diaphragm descends, and passively, and air flows in because of the creation of the negative pressure. And exhalation is just on passive recoil. So oftentimes this can be used on our neuromuscular disorder component or in acute or chronic respiratory failure issues. Continuous positive airway pressure, or CPAP, is air that's delivered at a specified pressure throughout the respiratory cycle. It keeps the upper airway open and prevents collapse. So this is often used in sleep apnea and in COPD. Because it keeps the airway open longer and prevents that collapse, then you can often get more air out that was trapped during obstructive disorders. But forced air at a set level is going in at all times, so you are fighting that flow of air in as you breathe out in the cycle. So there's also bilevel positive airway pressure. This is high pressure delivery on inhalation and a lower pressure delivery still in on expiration. So if someone cannot tolerate CPAP, then they may try BiPAP instead. Recovery of vital signs happens faster on BiPAP versus CPAP with acute pulmonary edema. And can be used if somebody has a significant CO2 retainer, then this might be used because it's easier to breathe off because the low pressure delivery on expiration versus a constant pressure. A few quick clinical pearls and then we'll be finished. So Flow needs are different at rest, sleep, and activity, and so we have to monitor the different levels of activity to determine the needs of our client, and we are the prime person to do so. This means that we have to be comfortable talking with our physicians. And then flow rates need to be are different based on the different pulmonary diagnoses. So pulmonary fibrosis and pulmonary hypertension will often need a higher flow to keep their saturation levels up because of the compliance of the lung tissue. Asthma and COPD may need higher flows just during activity with their dyspnea on exertion kind of ideas. And then what about our CO2 retainers who this is someone with a chronic obstructive, often disease of cystic fibrosis, or our COPD patients with chronic bronchitis or emphysema dominant. So oftentimes this person is considered a carbon dioxide retainer when the PCO2 is greater than 45 millimeters of mercury. And so the metabolic system over time accommodates for the high level of CO, and the client is not in acute respiratory failure. But the problem is that we become sensitive to oxygen rather than carbon dioxide changes. And so instead of us breathing deeper to breathe off CO2, instead we become sensitive to the oxygen, not the CO2 level. So if we give this person too much oxygen, then their body is sensitive to that. And so they change and they think they're having too much oxygen, and so they reduce their respiratory drive. And so if we are working with someone and we are providing support by titrating their oxygen during activity, we need to remember to turn that oxygen back down to their at-rest level before we leave the room, because otherwise this person may reduce the respiratory drive far enough that they become somnolent, confused, and they have low SpO2s, even though we're still on oxygen. So just be very aware of that.